So welcome everyone. Thank you very much for joining us this evening. I do appreciate that everybody's after work, busy days, Thursday evening, but we'll keep it as short as possible. We are excited to have you here and appreciate you taking your time, your private time to join. Today's session is designed to strengthen our partnership by ensuring you have the knowledge, tools and confidence to succeed with substance use service provision, which you probably do provide substance use services if you are joining this training. And obviously, we treat you as an extension of the service because we value your role as a partner and especially you looking after people we support as well. Let me briefly introduce today's session and people involved. We will start with a quick overview of who we are and our goals. Then we will move into the core training content where we will walk you through the key substance use agenda. We'll also highlight resources available to you and share practical insights you can apply into your practice right away. Finally, we will leave some time for questions and discussions at the end. Our goal is by the end of this session, you will feel informed, aligned, and ready to move forward with confidence. Few keeping rules. Please keep your audio on. Hopefully you can hear us okay. If you like to keep camera on, that's brilliant. We love seeing some interaction and some faces. However, session is recorded, so we do appreciate if you prefer to keep your camera off, or if you are unwell, or if you are eating your dinner in the meantime, please do as you feel. We will keep that session muted. However, at the end of the day, please unmute. At the end of the session, please unmute yourself. And if you have any questions you would like to take part in the discussion, please join in. And this is the safe space for learning. So please ensure that anything which is discussed in that session stays within our profession. And also, if you have afterthoughts, any concerns, please keep in touch, because we would like to make sure that you have full understanding. We can support you in providing services and looking after people better. So I've been talking a lot without introduction. My name is Barbara Zub and I work as a National Pharmacy Technician for Pharmacy and Medicines Optimization team at Waythrough. And I support likewise Sheffield in terms of pharmacy and medicines optimization agenda. So I will go to my colleagues from likewise Sheffield next. Betty, would you like to introduce yourself?
I'm Betty Kirkson, lead nurse at Likewise. I'm responsible for the health and wellbeing team. So that's the team of nurses delivering nursing interventions and supporting across the service. And we also have responsibility for the sexual health, respiratory and wound care pathways within the service.
Great. Thank you, Betty. Shelley?
Hi, I'm Dr. Shelley Jackson. I'm the specialist doctor lead at Likewise. So I work with the clinical team where we're offering primarily OST to our opiate dependent patients, but we also work with a number of patients who are using other illicit substances, prescription only medication, over the counter medication, and alcohol. Nice to meet you all.
Great, thank you, Shelley. And we also have our special guest on the call tonight, Melissa. Melissa is a part of Lived Experience Council at Waythrough. Melissa, would you like to say a few words?
Yeah, hi everybody. I'm Melissa. I'm on the Waythrough Life Experience Council. Just try and use my lived experience to help others really.
Fantastic. And thank you, Melissa, for being here tonight. Always lovely to have you. Okay, so let's start. Waythrough Services, brief introduction to the organization because you are more familiar with Likewise Sheffield. Waythrough works in partnership with the NHS, OHID, and also other organizations, obviously Community Pharmacy as a main partner. Way-through services are commissioned through local authorities, and we support people with various needs. Substance use services are our main agenda. So obviously we support people who have alcohol dependency, dependency with opioids, benzodiazepines, any other substances. And we do provide holistic approach to recovery, but also we support people in terms of mental health, housing, learning, education, and development as well. In terms of Likewise Sheffield, like I said, you are more familiar with Likewise Sheffield as your local service. We've had that contract in Likewise Sheffield from 2023, from 1st of August. Maybe someone has been on open days, Open Door Day in Likewise Sheffield last year. It would be good to hear if you were. It is integrated service with over 145 colleagues, staff. And we cooperate with a lot of organizations, for example, police, probation. There is a numerous number of teams which support people in their recovery, including criminal justice, outreach. You probably come across some of the people, like, for example, recovery navigators coming to your community pharmacy, or you've been discussing things with recovery navigators as well. So it's one of the largest services we have contract as a way through. I'm not sure, Shelley, Betty, would you like to add anything in terms of Likewise Sheffield?
Not really, other than we work with a lot of partner organisations across the city. You may have mentioned that, but we do a lot of work with SWAP and the Arch Project and the homeless organisations such as Ben's Centre as well. So yeah, there's a lot of sort of partnership and I would say sort of joint working that goes on out of Likewise.
Yeah, great. Thank you. And, you know, if you would like to take opportunity to go and visit Likewise Sheffield at any point, you know, find out more what's happening and how the work looks like in terms of being in the service and what we do, please contact Likewise Sheffield, because we are more than open to host you. And you have probably seen some invitations for training, for example, naloxone training, to carry naloxone on you, and you know, any other opportunities, just please pop in and say hello. As you can see, the whole team is very smiley, welcoming, so I believe you would have a good time and really good learning opportunity as well. So why do we provide support to people who use drugs? 1 in 3 adults have used illicit drugs in their lifetime. You probably know someone who used drugs, and you see how many people you know, come for any support to community pharmacy in terms of services you provide. So oral opioids.
Barbara, I'm back. I'm here.
Oh, Naeem joined. Oh, fantastic, Naeem. Sorry. I started presenting your presentation as I haven't seen you, but good to have you on the call. So Naeem, before you start, please introduce yourself, because we've done introduction already.
That's fine. Sorry, yeah, I just caught up in something. My name is Naeem, and I'm the harm reduction lead for Likewise Sheffield. So yeah, that's me. Do you want me to carry on with this?
If I can finish if you want to, but you are more than welcome. I've only started, so yeah, go for it.
That's fine. You can finish this slide and then I'll do the next one while you've started already. So yeah.
Okay, you will be doing one of my slides then.
No. I'll do the next one.
So, like I said, 1 in 3 adults have used illicit drugs in their life. And we can see the trends. You can see the numbers, but we can see the trends in terms of the numbers of people coming to treatment and using illicit drugs, and also in terms of the numbers because of drug-related deaths. And that is due to multiple factors. For example, new drugs emerging on the market, which are very potent. And if any of you have done naloxone training, this is what we also educate in terms of what drugs are there on the market. So drug use can vary. It can be from stimulants, which is very common, opioids, benzodiazepines, alcohol, which we all know, it's widely available, cannabis, ketamine, and many other substances. Okay, Naeem.
Yes, that's fine. I'll take over. Thank you. So we kind of try and support people and try and reduce drug-related deaths. Barbara just mentioned in terms of naloxone, and some of the pharmacies are also issuing naloxone. I'm not sure if you yourselves are. So it's really kind of, we're really trying to push naloxone out in the city, and we've kind of managed to really get it out there. And there's been a number of lives saved. I mean, you've got Betty here who's done, I don't know how many, but she just did the last one. Was it last week you had one? So it is about really saving lives. And as you can see on the previous slide, the numbers are still slightly going up year on year. So, and I think that mortality rate could have been a lot higher, especially in Sheffield, definitely, because of the number of people who use. So we really try and push it out there. There's also now a consultation going on in terms of from the government around being widely available, similar to DFibs as well, they're talking about. So government are doing a consultation, and they're also looking at widening the reach in terms of naloxone. So it's really kind of really important in them terms. And the reasons for that is because people are using substances, and the substances people are getting now, they really don't know what they're getting. They might be buying, they think they're buying benzos, for example, but it could have nitazines in it. It could have fentanyl, it could have xylazine, it could have a range of different things. And that's the kind of scary part at the moment in terms of the drug market. So it's very volatile, and what people are getting their hands on, what people are using, thinking they're using. So it's really kind of big push in terms of trying to reduce and save as many lives as possible. We will work towards people's goals as well. So some people, and we have to be honest, some people never want to stop using. So we try and kind of minimize the risks for them. So we don't eliminate the risk, but we try and minimize the risks in terms of if they are injecting, making sure they've got clean injecting equipment, right advice, they're using the correct needles for the correct sites, or if they're smoking it, they're using the correct equipment to smoke the substance that they might be using. So we kind of focus a lot on in terms of giving harm reduction around that. And it's also around obviously lowering BBV risks and infections that our client groups, DVTs, infections, cellulitis, ulcers, all these kind of knock-on effects from poor injecting practices. So we try and really push that. And also mentioned about the contamination in some of the substances around currently. So using substances can cause, and we know it impacts on everybody and everything around them. So it's not just simple as, it affects their family. And that's why one of the reasons why we have such a, I suppose, I think Shelley mentioned we have about 145 staff, different teams, because it's not as simple as I always reference here. It's not a light switch you can just turn on and off. There's a lot of factors in it, and there's a lot of support networks. So we try and kind of, I suppose, reach out. So we try and support family members and providing a more holistic approach. It could be loved ones, it could be friends, could be absolutely anyone. So it does impact on people's relationships, employment, families, violence, and impact on children, as we know, and safeguarding. And we work quite closely with safeguarding services. And it's not always about, I suppose, taking their children off them. It's trying to better their lives. And that's the angle that they usually come in with. Sometimes, unfortunately, they have to take that step. So mentioned in terms of needle use, so we try and, we're really pushing in terms of people getting the right equipment and the clean equipment and the correct equipment. So we're going to be doing some other schemes in terms of trying to increase needles being given out, clean injecting equipment given out, city centre, we're looking at doing backpacks, a mobile delivery kind of a service. So yeah, we also have criminal justice within our system. So criminal justice is the only real team where people, I suppose, have to come in, for example, if they've had a court order or their own license and they have conditions that they have to apply, they have to attend. So it's only within that team. The rest of us don't, it's a voluntary service for us. So not everybody, we can't force anyone to access services, we can't force anyone out. So it's about voluntary and it needs to come from them. But the criminal justice team, yeah, they definitely look at cells, they work in prisons, they work in the courts, and they work alongside probation, the police, and trying to give that, again, looking at more holistic and meeting requirement orders that they might be given in courts instead of sentences, for example. So total cost 21 billion in 2023. Drug-related crime contributes, shoplifting, burglary, crime. So what you see at the bottom there, every pound spent on treatment is £2.50 saved, I suppose, if we look at it from a financial perspective. So it's well money spent in the long run. And thirdly, this is you, Barbara.
That's fine, Naeem. Thank you very much for
you.
that introduction and explaining why we are providing that support. It's a bigger picture, isn't it? Let's move into the main content of today's session. What we'll cover by this training is opioid substitution therapy, other pharmacological therapies, supervised consumption, which probably is one of the services your pharmacy provides, missed doses management, and also how we can work in collaboration for people we support to have the best outcome. So I would like to invite Melissa to share her experience using community pharmacies to get her medication and the real difference and the impact some of the practices made actually to her recovery. So Melissa, please share a few sentences around your recovery and the interactions with lovely community pharmacy colleagues.
Okay, hi, I'm Melissa. These days I'm a sociology student. I work with young homeless people. I'm rebuilding relationships with my family, with my children, and I'm living in a nice little flat with my cats. And I've got a very normal life, really. But then I'm also somebody with a lot of lived experience of addiction and supervised consumption. So I was in active addiction for many years, really. I've used supervised consumption services for buprenorphine and methadone. I've actually used both of the pharmacists that were mentioned in the chat. I've attended the Wicker and Low Edges as well, and I've got nothing bad to say about them. So yeah, like the most important thing is just normalizing the experience. Like it shouldn't feel like a shameful experience. You're just going to get your medication, and generally you want to be treated like any normal customer, really, which you are. But sometimes supervised consumption can be the first bit of stability that you might be experiencing if you've got quite a chaotic life. And for me, it meant that I was safer. It meant that somebody cared enough to notice if I wasn't okay. And just somebody remembering your name and asking how your day was, or just remembering little things about you that's not part of your addiction. You know, how's your cat? Or, you know, remembering you've had your hair done, or just little things like that. And generally I have had like really good experiences. Like with anything, you get the odd bad experiences, but it's the good ones that stick in my memory more. You know, for most of the time, for people that do use drugs, pharmacists are the health professionals that they're going to see most often. You see them far more than your GP. You see them even more than your recovery worker. So their impact is going to have an effect on your life. Just trying to be consistent and predictable, and remembering somebody's name, the important things like confidentiality and privacy, and just small bits of respect, being treated like a human, not just your addiction or your problems. So yeah, and then on the flip side of that, little things that might seem insignificant, you know, like eye rolls or being spoken to loudly, those little type of things can stick with you when you're already feeling quite shameful, and you know, it could be enough to stop you going back to the pharmacy. But yeah, I'm in recovery now. I'm studying and I work with young people. And when I look back, the pharmacists that I have engaged with were a big part of the picture, whether they realised it or not. And there is some of them that I still go back to when I'm passing the pharmacist, and I'll just go in and like check in with them, tell them how I'm doing. So yeah, that's it.
That's very powerful, Melissa. Thank you very much for sharing that experience.
No problem.
Yes, it's amazing to hear that many, you know, probably colleagues you've come across are on the call, and that you share that experience also from pharmacy colleague perspective, because we very often we just provide the service and we are kind, and those small acts of kindness are often something normal to us, but it shows that actually they can have a massive impact on someone being not in the great part of their life. So thank you very much. That's very powerful, Melissa. Thank you.
Thank you.
Okay, so moving forward, we would like to give you some CPD material. So a bit of going through pharmacological therapies we can use. You can see on the prescriptions, so we've got better insight into the medications we use to support people with that. So I will leave that to Shelley.
Hiya, thanks, Barbara. Hello, everyone. I would imagine most of you on this call know a little bit about these medications, if not more than me in some cases, but I'll just run through the two main medications we use for OST, so opioid substitution therapy. So methadone, as you probably know, comes as a green liquid, either sugar-free or otherwise. It can also be prescribed as a tablet, which we often use for holiday prescriptions, so people traveling, particularly if they're using air travel. It is also prescribed as ampules, although I think currently we possibly only have 1 or 2 patients on those at the moment, and certainly as far as future prescribing, that isn't something that we generally start patients on. We also use buprenorphine, which is a partial agonist-antagonist, and again, as you know, comes as a sublingual tablet or as a wafer, commonly known as Espinor, and also the new formulation as the Buvidal depot injection, which we'll touch on in a later slide. So just a little bit about the pharmacology, which feels odd when I'm talking to pharmacists, but methadone has obviously got quite a long half-life, 24 to 36 hours, and is designed to be given once a day for OST. It can be given more frequently when it's used for pain management, for example, but obviously that's not our main remit. It tends to give you less euphoria than heroin. Still, I describe to patients as a slightly cloudy effect, and often that's part of the decision making when they're thinking about methadone versus buprenorphine. Obviously, we have to be aware of methadone in terms of its risk on the heart, in terms of QTc prolongation, particularly when patients are using other substances or they're prescribed other medication that could interact. The optimum dose is 60 to 120 milligrams, but again, that's dependent on the tolerance of the individual. And as I'm sure a number of you know from the scripts that we use, we tend to start at a low dose according to our guidelines, or a suitable dose, should I say, and then titrate over a short period of time to hopefully stabilize the individual on medication. We also use it in pregnancy, and it tends to be first line in pregnancy if somebody's not already in treatment. However, we can use buprenorphine in pregnancy if it's patient choice or they're already established on it. So buprenorphine, Again, long half-life, so it's a once daily dose, and as I've mentioned earlier, slightly less sedating than methadone. Often that can be appealing to patients. It tends to be safer than methadone in overdose because it has like a ceiling effect, so the effects level off at higher doses, so it lowers the risk of respiratory depression and overdose. So yeah, both of them definitely have a place. We've mentioned briefly at the bottom of this slide about what we call SROM, which is the slow release oral morphine. We do have a handful of patients still on that. Historically, they're patients who are probably previously on diamorphine, ampules. So we still do prescribe that, but again, it's not something we tend to start, and it tends to be historical prescribing. In terms of can I have the next slide, please, Barbara? In terms of the actual evidence, oh no, the one before it, my apologies. In terms of the evidence base for OST, it probably speaks for itself to a certain degree in that what we're trying to do is reduce the risk of drug-related deaths, but we're also reducing the risk of harm. So patients, obviously in an ideal world, we like to stabilize them in treatment for a short period and then maintain them briefly and then start to reduce their medication in a planned, structured way in order to hopefully exit them from treatment drug-free. I see methadone and buprenorphine, I sometimes describe them as crutches to patients because they're there to support them while they start to achieve stability in other aspects of their life. So improving their health, their relationships, their housing, you know, start to sort of build bridges with their families if that's needed. So it's very much for me medication there to support them. As I mentioned earlier, there are therapeutic doses. Methadone 60 to 120 and buprenorphine 8 to 12 milligrams. What we do know is that people who use drugs and they're not taking methadone, and this is evidence-based, are 4 times more likely to die than those in treatment. And people in treatment on methadone are more likely to stay in treatment if they're not on OST. And I guess a lot of that is fairly common sense. It obviously reduces the risk of intravenous drug use and the associated harms, things like bloodborne virus and HIV. So yeah, so I hope that just, you know, captures the 2 main medications that we currently use, and I'll hand over to my colleague to talk about long-acting buprenorphine, commonly known as Buvidal.
Yep, so Buvidal is something that you don't generally see in community pharmacies, but we administer it here in the service. We did initially introduce Buvidal as a treatment option a few years ago. In fact, it was at the old service at Fitzwilliam Centre. And we currently have around 130 clients on this treatment. And the capacity for more, we've got capacity for up to 200 at the moment. So we can use Buvidal as an aid to detox or as a long-term treatment option. And we can transfer people onto it from a buprenorphine dose, as you can see from that table, of 8 milligrams, well, generally from 8 milligrams to 24 milligrams for the monthly dose, which is the one we tend to use primarily. So Buvidal is a long-acting injectable form of buprenorphine, and it's designed to provide sustained medication levels over time. So it helps people manage the cravings and withdrawals and reduces the need for daily dosing and attending the pharmacy regularly. So people don't get those peaks and troughs associated with the daily dosing. And the half-life of the monthly medication is 19 to 25 days. So it stays in the system a long time, tapers off very slowly, and so you don't see those problems with withdrawals when you're coming off it as well. So Buvidal's given as a subcutaneous injection, where it forms a depot under the skin, and then the medication is released slowly, providing continuous treatment, like I said, generally over a month, although weekly options are available. So buprenorphine is partial opioid agonist, so it activates the opioid receptors enough to prevent withdrawal and cravings, but has that ceiling effect that lowers the risk of overdose compared to full opioids like heroin or methadone. It can provide consistent medication levels compared to daily oral medications and reduces the burden of frequent pharmacy attendance. And for many people, it supports their recovery by offering stability without the daily reminder of medication, and can help patients focus on their wider recovery goals, such as, employment, their relationships, and their overall well-being. I think back to you, Shelley.
Yep. Hi. So we just wanted to touch on a couple of other drugs, I guess, that we come across, prescribed or otherwise. One of the substances that we do see in Sheffield, both prescribed and used illicitly, are benzodiazepines. So again, as I'm sure you know, there's a range of benzodiazepines. We tend to see more often than not diazepam and nitrazepam. There are a few patients still prescribed temazepam, but we are working on that. So in terms of benzodiazepines, it's not licensed for maintenance, and there's really no evidence as to the benefit of long-term prescribing. So our patients tend to use them along with other medications, often as a secondary drug. It might enhance the effects of the primary drug they're using, or help them with withdrawals from other drugs, help them manage their stimulant use, and in some cases replace alcohol. As I'm sure you're aware, there's quite a substantive evidence around a withdrawal syndrome from benzodiazepines, so it's not something that we would encourage patients to stop suddenly, particularly if they're on prescribed medication. What we offer at Likewise is support around managing their illicit use, and we can offer a lot of interventions around how to safely reduce, along with that sort of psychosocial support that they'll access from their recovery navigator. We do in some cases offer community-based reduction programs that can take several months depending on the speed of the reduction, and we've got a lot of sort of policy and governance around who we offer that to in terms of then taking on prescribing of benzodiazepines. We have a number of patients who are on it through us, on prescribing regimes. And again, we are, we're working quite hard to start to manage those patients around coming off that, in a shared way, rather than stopping their prescription suddenly because of the risks I've mentioned above. The other service we kind of offer, or we certainly see patients, and I would like, probably anecdotally fair to say that we've got increased numbers coming through our service now who are using over-the-counter medication and prescription-only medication. So that can, commonly we think of codeine-based medication, so cocodamol, sulpidine, diadrocodine, etc. But obviously we do see patients using gabapentinoids as well. As a service, we tend to offer a similar approach to what I've just described for benzodiazepines, so working with the patient to self-reduce. If it's prescription only and they're receiving it from primary care, for example, we will work with a primary care provider to support them to reduce the actual medication while we do more of the wraparound support for the individual. Occasionally, we do move patients from over-the-counter or prescription-only opioids onto OST, and often we will consider buprenorphine as the choice for that, and those patients can do very well in terms of moving on to OST. I guess as far as community pharmacies are concerned, you will be seeing these patients coming in, buying over-the-counter opioids, and just to make you aware, I'm sure you are already, that we are here and ready to sort of support and assess them. So please do signpost to us if you do have any individuals who you feel would benefit from some input. Thank you.
Yep, I'll come in for the alcohol part. So Alcohol is a bit of a separate pathway in the service, but all clients seeking support with their alcohol use will receive a comprehensive alcohol assessment with one of the nurses. So as part of that, we come up with a plan as to kind of what path they take in terms of their recovery, and especially if they're drinking independently or not. So we provide alcohol detoxes for people who are drinking independently using chloride epoxide on a reducing regime, usually over the course of 8 days, but we can do slightly longer detoxes if possible, if need be. So depending on the needs of the client, we can do this in the client's home if they have the support around them at home, if they've got someone to kind of look after them and keep an eye on them while they're in the process of detoxing. We also have access to recovery beds at the Greens up in S5. So there we can send people who might otherwise be suitable for a community detox but don't have that social support around them. And we can keep an eye on them there and keep them safe throughout the course of their detox. For clients with higher needs, such as previous detox complications, risk of withdrawal-related seizures, complex mental health needs, we can refer to inpatient detox units outside of Sheffield. And one of the other things we offer for alcohol clients from, well, as soon as they come into the service is prescribing thiamine. As you'll probably know, chronic alcohol use can reduce thiamine absorption, and thiamine's essential for nervous system health. And prolonged deficiency can lead to quite significant complications down the line, such as Korsakoff syndrome. So we like to prescribe thiamine as soon as we can. Post-detox, there are other medications available. So these are the three that we use: acamprosate, naltrexone and disulfiram. So they're medications used to support people after detox with their abstinence. They do work in different ways, and we choose them based on the client's individual needs and goals, and also the medical suitability. So acamprosate works by stabilizing really the brain chemistry disrupted by long-term alcohol use. It can help reduce cravings and the emotional distress associated with abstinence. Acamprosate is most effective when someone has already stopped drinking and wants to remain abstinent. Naltrexone is an opioid receptor antagonist, and reduces the rewarding effects of alcohol, so it can help decrease cravings and risk of relapse. And it's also suitable for people aiming to maintain abstinence. We also use naltrexone in opiate abstinence, and it's used in gambling addiction as well. And disulfiram, which is known also as anti-abuse by a lot of people, works by blocking the breakdown of alcohol in the body. So if alcohol is consumed, it causes an unpleasant physical reaction. So you can get the flushing, nausea, palpitations. So we really need someone to be motivated if they want to start disulfiram. We don't generally use it first line, but we can use it in people really committed to complete abstinence.
Great, thank you very much, Shelley and Betty, for those insights. The other medication we support people with is naloxone, and naloxone is the opioid antidote. It's the opioid receptor antagonist to be used in case of overdose and respiratory depression. It is available as nasal spray or injection. Some colleagues probably have been trained to provide naloxone, because naloxone is one of those services you can provide from community pharmacies. and it's for both distribution of naloxone kits to people who may benefit from it, but you are also trained to how to administer naloxone in case of emergency. So if you have someone overdosing in the pharmacy, you can actually support that person. And we have one pharmacy in Sheffield who's already saved 8 lives since they've been trained. So, you know, it shows its benefits, and it's another thing which helps supporting people and keeping them alive. So please, if this is something you would be interested to provide, please contact Likewise Sheffield or myself. I will leave them some contact details later on. Training is quick, fast. Now it's available online. You can do it as your CPD, and the whole setup is very quickly. But there is plenty of benefits. We can't really appreciate how many, and appreciate people who carry naloxone and support people this way. So in terms of drug-related deaths, obviously we link it with naloxone, and like Naim mentioned, it would have been much higher number if we didn't have that intervention. But in terms of methadone and buprenorphine themselves and how they work, you may ask, you know, about their safety. So Shelley, would you like to say a few words around the difference between methadone and buprenorphine, and why buprenorphine now is not as much supervised as it used to be?
Yep, thanks, Barbara. So I guess this slide just shows, doesn't it, really the kind of risk that our pose to our patients, and obviously there's a bit of a skew towards males versus females in terms of drug-related deaths. OHID, there was some guidance that came out last year, which really has kind of changed some thinking around how we prescribe buprenorphine. So dosage, etc., is all the same. But it's felt through evidence that buprenorphine is much safer than methadone. I mentioned in an earlier slide, it's kind of got a ceiling effect, so the risk of overdose and respiratory depression are, well, much less than methadone. So it's felt that a change in the way we manage prescriptions. So, for example, previously it used to be daily supervised consumption for the first 3 months, etc. in the Orange Book. We've kind of moved on a lot from that with buprenorphine, and we can offer a more flexible approach. And the hope is that that will remove some of the barriers that are there for patients when they are coming into treatment. You know, that can be both ends of the scale, patients who struggle to get to the pharmacy daily due to their complexity and chaos, or patients struggle because they're working, for example. So yeah, it's really helpful, and you know, it's taken a bit of a switch in the terms of the way we think about it when we're supporting patients. Thank you.
No, that's amazing. Thank you very much. But we will still have some patients having that supervised consumption advised. And a few words around that for those who provide supervised consumption or would like to provide supervised consumption service for us. We do provide the care in terms of the person as a person-centered care, and we believe that this is what's happening in the pharmacies as well. So we've got a bit of guidance here about how to provide it, but you may have different arrangement with the person because that was the person preference, and I come across that quite a lot when I speak to pharmacy technicians who provide supervised consumption. So one person at a time. This is simple, and this is how you serve people. Just ensure privacy, dignity, and confidentiality, and that this is maintained as any other medication, any other interaction you've got with the person. Obviously, date of birth, check, name, address. It's crucial. We've come across few incidents where the medication was given to a completely different person. So please, this is something we should be checking anyway as a standard procedure. Medication name, formulation, and dose. In terms of supervised consumption and medication we prescribe and blue prescriptions, you can see frequent changes to the doses because of titration up, titration down, people changing the doses because of the dose optimization. So always check that when you provide the medication. And in general, you've got opportunity to check on the person. You know, is that person looking okay? Is everything okay in terms of you know, how the conversation goes? Is the person intoxicated? Has the person actually been collecting medication? Because in some circumstance, for example, if the person missed 2 doses, it would be worth to, and we ask to provide the information to the service. But if the person missed 3 doses, then there is like a bit of risks associated with it if you dispense the medication to the person. So always contact likewise Sheffield, alert prescriber, and we can have a conversation if it's safe to dispense the medication to the person. And also, any patterns in terms of missed doses, for example, that person doesn't come on Monday or Wednesdays, just let us know, because then we can adjust the prescription to the person's needs. It might be some other reasons behind person not collecting medication. In terms of the procedure, it's very easy. So in terms of the methadone, you can dispense in the bottle or the dosing container. After the medication is taken, engage in the conversation. Just have a friendly chat before that person leaves. So to ensure that the person is okay, and also you can ensure that the dose has been taken. A drink can be offered if needed. It's not necessary, but some people may prefer, again, that person-centered approach. The only drink would be water from your pharmacy, just to ensure that there is a minimal risk of diversion. You can also see some of the benzodiazepines being prescribed as supervised consumption scenario. Here we've got example of diazepam. Again, offer water before, because the mouth can be dry. Those placed into disposable pot for self-administration. Drink water after administration, and again engage in the conversation as a part of the check and checking on the person. Slightly different will be for buprenorphine sublingual tablets or Espranor wafer. So check hands are dry, because we don't want the medication dissolve on the a bit of water on hands. Drink water before, and then put the dose for the person to just place it under the tongue in terms of buprenorphine, or on the top of the tongue for Espranor, because that dissolves slightly different. And encourage person to actually hold the saliva for a bit longer in the mouth, because of how the medication is being absorbed. And in terms of the services you provide in your pharmacy, there is plenty you can choose from. Supervised consumption, which we've just discussed, needle exchange, and also naloxone services. They are all paid, and there are service level agreement in place. So why we ask pharmacies to provide supervised consumption service? It is user-friendly and non-judgmental, person-centered and confidential service. We ensure that, because we can't and we are unable to see the person every day, that person has got regular contact with healthcare professionals. And you are healthcare professionals who can support people with any queries they will have about their medications, but also other needs, like maybe that person qualifies or may use pharmacy first service, or, you know, a BP check, other services you can provide. So take that opportunity to check on the person and actually, you know, encourage to take advantage of those services. And those people very often may not be wanting to go to GP in terms of any health problems they may have. You are that contact, and you can actually make a difference. Like Melissa said, you have a massive impact on patients, on those group of patients' recovery journey. Also, we can ensure that the medication is being taken as it should be, especially at that early stages when the medication is introduced. So you also have it's not the service itself, but it's part of service level agreement for supervised consumption. It's monthly OST payment for just holistic approach to that person and just offering that support as person need, and also having that collaboration with likewise Sheffield, report 2 missed doses, report 3 missed doses, report any concerns you may have around the person, because that helps us with providing better care for them as well. So in terms of missed doses, Betty, would you mind briefly to tell us a bit about the poster and what we would welcome from community pharmacies in terms of missed doses?
Yep, I will do this very briefly because I know we're running out of time a little bit. So we did notice when we changed services over from Fitzwilliam Centre to Likewise that we lost a bit of that communication and those really good relationships we had with community pharmacies, and we thought we had a drop in the number of notifications we were receiving. So I had a look into that and looked at the restart appointments within the service and reviewed the notes to see where we'd received notification from pharmacies, where we hadn't, whether it had been documented properly at our end. And we found that out of 140 restart appointments that I reviewed, only around a third of those I could find evidence that we'd documented that a pharmacy had contacted us. So on the back of that, me and Barbara met with Community Pharmacies South Yorkshire to look at if there were any barriers to pharmacies reporting missed doses and if there was anything we could do to support. And we also offered a dedicated phone line, email address, and of course we still have the farm outcomes reporting. And then we sent information packs out to all pharmacies, which you should have received. One of the things in those information packs was the poster on the screen there, which I hope everyone has put pride of place maybe on the front of their CD cabinet. That would be very helpful. It's got all the information there as to how and when to contact us. Can I have the next slide, please, Barbara? So yeah, once we'd done that first round and put a few things in place, we did it all again. As you can see there was some improvements across the board. We actually found that there was quite a significant improvement in documentation that pharmacies were contacting us when people were either off script or had missed 2 pickups. And we also, on the back of that, looked at improving internal documentation so we could make it clearer that the pharmacy had contacted us. So one of the things I was hoping to ask as a maybe a discussion point at the end, although I could see there's even less time now, is if there's anything else that we can do to improve communication with community pharmacies.
Great, thank you very much, Betty. And it was, I think it's also worth to mention that finding that we found during that audit that some of the missed doses were actually some safeguarding issues. So people not picking up medication and missing doses. It's not about them not wanting to go to pharmacy. Sometimes they may be just withheld, they cannot leave the house, or, you know, that will give us opportunity to check on the person actually what's going on if, you know, if there is no background story to it. So in terms of communication, I hope some of you have seen our newsletter for community pharmacies providing substance use services. We issue it quarterly, and it's something we share our knowledge, because I do appreciate that substance use in general it's not sometimes white, black and white, and we still are seeking kind of research and support in terms of having that information. It's not much out there, so that's why we want to share it with you, and we would appreciate any you know, any practices or any comments, any feedback in terms of, or any queries you may have, because for us it's also learning opportunity that sometimes we just assume that it's known, and you may just raise something which you know, it's a problem for you. So please reach out and have a look on those resources. They are always uploaded to Pharma Outcomes. So if you go to Pharma Outcomes, you can actually see in messages. However, they are also available on Waythrough website, which I shared in the chat as a reference. I will upload everything to Pharma Outcomes to have it in one place after the training session for you. But yeah, just check those messages regularly as well, because we share that on this and with a Community Pharmacy South Yorkshire newsletter also. So we've got a few minutes, and I think it would be, we've got some few cases prepared, but I would appreciate maybe some questions from the crowd, or anything you would like to mention, anything you need support with. Is there anything which really bothers you, or you know, you would like to share in terms of our collaboration? I would welcome any questions. Just unmute yourself and ask. Is there anything from anyone? Anyone would like to maybe give an idea how to improve that communication between Likewise Sheffield and Community Pharmacies? Is it working for you okay? Betty was hoping for some good ideas and brainstorming session. If not,
Maybe
we may
it's too
actually
late
do
in the day.
It is, I do appreciate. So I will also maybe just say about that case study briefly, and I would appreciate if someone engaged. Oh, we've got Martin. Good evening, Martin. Unmute yourself.
Good
and
Good evening. It's a question that came up today that I was asked.
okay.
Why are we still using sugared methadone? Why don't we just move entirely over to sugar-free?
Okay, I'm not sure if Shelley, as a prescriber, would like to answer that question. Shelley, I don't want to put you on the spot. I can only say this is it might be patient preference because of that person-centered approach, and there is still an option. But Shelley, would you like to give insights about sugar methadone prescribing?
It's tricky, isn't it? Because I kind of agree with Martin to a certain degree, but I think it probably just comes down to patient choice, and that in national guidelines it's still there really. But yeah, it's definitely worth thinking about. I can't think of many now that are on full fat, as I call it, methadone. So yeah, I know what you mean, Martin, but I think it's another choice thing, isn't it? I mean, we still get patients who, as you probably know, make choices about the type of buprenorphine they use for various reasons, and I suspect there's a similar cohort of patients who feel the same about sugar-free and sugared methadone. So yeah, I hope that helps, but I know where you're coming from.
And I think it also worth mention here, Martin, thank you for raising it, that there is still a lot of myths around opioid substitution therapy, and there is plenty of like myths, you know, that people don't want particular medication, particular brand, that, you know, sugar-free may be less effective than sugar one, you know, methadone goes to your bones. There is a lot of myths which you know, it's something we come across quite a lot actually, but it's something we can definitely look at and audit those patients just to check. It's definitely less frequent prescribing compared to sugar-free, because we want to make sure that appropriate hygiene as well, and impact of sugar. But yeah, it's something we come across quite a lot. So thank you. It's something on the task list, Shelley, to review those patients. Is there anything else? Oh, thank you, Betty. Betty just mentioned that never seen a problem with sugar-free methadone, but I've seen I've seen a lot of problems in terms of dental care. Yes, I do agree. Okay, well, that will bring us to the end. What I would like to encourage everyone is to keep in touch with the service. If you have any questions, any queries, or anything you would like to share, please stay in touch. And thank you very much for joining us this evening. And if you need any other required training, anything else we can support you in terms of harm reduction, needle exchange, any other training you would like and welcome, please contact us and we'll be more than happy to even come to the pharmacy and provide that. But for tonight, thank you very much and good night.
Thank you.
Thank you.
Thank you. Bye.
Bye.
Bye. Bye.